Hi everybody, my name is Kirsten Gordon and I'm going to be starting off our CLABSI presentation. First of all, what is CLABSI? CLABSI is central line associated bloodstream infections. It's defined as a primary laboratory confirmed bloodstream infection in a patient with a central line at the time of or within 48 hours prior to the onset of symptoms, and the infection is not related to an infection from another site. What is a central line? A central line is a type of catheter that is placed in a large vein that allows multiple IV fluids to be given and blood to be drawn. When compared to a typical IV line, a central line is larger, can stay in place longer, can deliver a greater volume of fluids, and allows blood to be drawn easily. Central lines may be placed when there is poor IV access with peripheral catheters, and they also may be placed for long-term treatment such as dialysis or in critical patients receiving multiple items via IV. What are the causes of CLABSI? Contamination of insertion site, the patient's skin flora, hub colonization, contaminated infusion or components of IV set, non-intact dressings. What are patient risk factors for CLABSI? Immunosuppression, age, poor nutrition, antibiotic therapy, position of the central line can also increase the risk of infection if it's ephemeral or internal jugular, and lengthy hospitalization before venous catheterization. Other risk factors include poor patient hygiene, healthcare workers using poor hand hygiene, not adherence to aseptic technique, type of central line and number of lumens, if it was an emergency insertion, non-compliance with central line maintenance, such as not using antiseptics or not completing dressing changes, prolonged duration of the catheter. The research question that our group came up with is, among ICU patients, what is the impact of advanced CLABSI prevention education compared to standard training on CLABSI rates over a 90-day period? Why is this relevant to nursing? Well, CLABSI is 100% preventable. It leads to longer hospital stays, on average anywhere from 7 to 21 days longer than usual. And it leads to an increased cost for both the hospital and the patient, and because they are preventable, insurance often does not reimburse for them. CLABSIs are reportable to the CDC, which can lead to poor perspectives from outside the hospital and can deter patients from choosing said hospital. Lack of education regarding prevention and recognition of CLABSIs are the two causes of CLABSIs. If we can increase education, then patient outcomes will be improved.
CLABSI prevention evidence-based guidelines were released in 2005 by the CDC and AHRQ. Measures include hand hygiene, maximal sterile barrier precautions, appropriate insertion site selection, and prompt removal of unnecessary catheters. By 2009, CLABSI reduction rate of 58% was identified. Due to the reduction rate of infections, 3,000 to 6,000 lives were saved and a cost saving of $414 million.
In 2012, the Institute for Healthcare Improvement created the Central Line Bundle, or CBL. The CBL consists of 5 components: hand hygiene, maximal sterile barriers, chlorhexidine skin asepsis, optimal catheter site selection, and daily review of line necessity to ensure prompt removal. In 2014, the Society for Healthcare and Epidemiology of America, or SHEA, developed guidelines with additional education for healthcare personnel and specific intervention at and after central line insertion, which you can see to the right. The implementation of the SHEA guidelines provide a generic framework for CLABSI prevention, which led to increased nursing knowledge of hub cleansing and physician dictation of line necessity and a decrease in femoral line utilization, which ultimately led to decreased rates of CLABSI.
The first case study that we're going to look at is a mixed study written by Hansen. The research question of this study was that evidence-based CLABSI training in the context of a caring, healing environment with an emphasis on patient safety would decrease ICU CLABSI rates in high-risk adults when compared with CLABSI rates from the same month in the previous year. The target population of this study was a large Florida community hospital. And the findings were that the training provided to the 150 participants of the study led to an increased knowledge of CLABSI and also an increased ability of participants to identify CLABSI earlier. The results are suggested that ongoing education is essential. There was no significant association between educational interventions and whether the staff labeled the pick dressings, changed soiled or loose dressings, or scrubbed the hubs. There was, however, a significant association between educational intervention and an increase in the frequency with which the needleless access ports were changed. There was also a significant association between educational intervention, grounded in caring, and the perception of whether or not mistakes are held against staff members. After the intervention, the staff felt significantly more confident in their ability to speak up when they observed breaches in pick care. The second case study was a qualitative study written by O'Neill and all the other authors. The research question was to evaluate a central line care maintenance bundle to reduce central line associated bloodstream infections in non-ICU settings. And the target population of this was a 1,250 bed teaching hospital. 8 wards were used in total, 4 served as control groups, and 4 received the intervention. The findings of this study were that implementing the central line care bundle had a positive influence on the physical care of the lines and did show a decrease of CLABSI incidence, but was not statistically significant. Minor details were noted to be missed, which could prove to be significant, such as mislabeling addressing dates or not labeling a date at all. In the end, more research is needed to determine true statistically significant information, but education is essential to decrease CLABSIs. The third case study is a quantitative study written by Krein et al. The research question was how often certain practices are used, including maximum sterile barrier precautions during central line insertions, chlorhexidine gluconate for site antisepsis, and thirdly, antimicrobial central venous catheters. Fourth, chlorhexidine impregnated sponge placed around the catheter at the insertion site. The target population of this study was 6 hospitals across the U.S., but this study is part of a larger study focusing on hospital-acquired infections across the whole United States. And the findings of this study were that implementation of education regarding prevention infections is essential for overall care of the patient. One form of education is not fitting to all hospitals. Each hospital and healthcare facility need to find a form of education that works for their specific facility, focusing on the specific facility's downfalls or the reasons that the CLABSIs are present in that hospital. The basics surrounding central lines are the same across the board, but the implementation and the teaching needs to be shaped for the specific facility. Continued study is needed to better understand this information.
Case study number 4 is a quantitative descriptive study. This is by Humphrey. The title of this is Improving Registered Nurses' Knowledge of Evidence-Based Practice Guidelines to Decrease the Incidence of Central Line-Associated Bloodstream Infections. The purpose of the study is to develop an educational intervention to improve registered nurses' knowledge of evidence-based practice guidelines to decrease the incidence of CLABSI. Findings in educational intervention can increase nurses' knowledge of care of central lines. Nurses' knowledge of care and maintenance of central lines increase statistically after the educational intervention. The relevance is increased education supports CLABSI prevention.
Case study number 5 is a quantitative descriptive retrospective study done by Kurlje and Katranja in 2016 titled One Rural Hospital's Experience Implementing the Society for Healthcare Epidemiology of America Guidelines to Decrease Central Line Infections. The purpose of the study was to review CLABSI rates prior and post implementing the SHEA guidelines. The findings were a decrease in CLABSI rates from 1.9 to 1.3 per 1,000 days while utilizing the SHEA guidelines from July 2007 to June 2010. The relevance of the study is the application of SHEA guidelines in hospitals with CLABSI occurring can reduce infection rate. It also reinforced the importance of ongoing education and evaluation of the consistent use of the SHEA method in decreasing current CLABSI rates. CLABSI rates at this facility remain below baseline using the Shea method for the calendar years 2013, 14, and 15 as well. Case study number 6 was a qualitative study conducted by Pham et al. This study was titled CLABSI Conversations, Lessons from Peer-to-Peer Assessments to Reduce Central Line-Associated Bloodstream Infections. The purpose of this study was to identify successful and unsuccessful areas of infection prevention and share best practices and insights by peer review. A team from a successful hospital with 0% CLABSI infection rates visited multiple hospitals to discuss their protocols and find places of error. The findings from the study include recommendations to reduce CLABSI related to management, responsibility, training, protocols, and review. The common practices led to 10 recommendations. Executive and board leaders communicate the goal of 0 CLABSI throughout the hospital. Senior and unit level leaders hold themselves accountable for CLABSI rates. Unit physicians and nurse leaders own the problem. Clinical leaders and infection preventionists build infection prevention training and simulation programs. Infection preventionists participate in unit-based CLABSI reduction efforts. Hospital managers make compliance and best practices easy. Clinical leaders standardize the hospitalized catheter insertion and maintenance practices and empower nurses to stop any potentially harm acts. Unit leaders and infection preventionists investigate CLABSIs to identify root causes, and unit nurses and staff audit catheter maintenance policies and practices. With doing these, CLABSI rate can be reduced to a rate less of 1 infection per 1,000 catheter days for at least 1 year in these hospitals. The relevance of this study identifies areas in which both low and high-performing hospitals in relation to CLABSI rate can improve and reduce their rate of CLABSI.
A quantitative descriptive design was used for this study. A convenience sample was taken within an ICU unit. Pretesting was used to establish baseline knowledge regarding evidence-based practice guidelines among ICU staff providing care for central lines. Instituting a 4-hour advanced CLABSI prevention educational program via interactive smartboard presentation. Improve the CLABSI reduction rates, improve knowledge of healthcare providers, post-testing to evaluate knowledge retained from advanced education program among ICU staff providing care for central lines.
Resources for this experiment will include hospital administration to approve the experiment and also for funding. Nurse managers on the unit will monitor compliance with the new protocol and provide guidance when needed. Nurse educators will administer pre- and post-testing regarding the advanced CLABSI protocol. They will also provide the initial advanced CLABSI education to ICU staff after the pre-test is given. For ongoing maintenance, they will provide annual advanced CLABSI education to ICU staff when off duty, and they will also provide advanced CLABSI education during new ICU staff orientation. An infection control team will be needed for data collection, and statistical analysis will be needed to interpret the collected data.
Stakeholders and outcomes. Hospital. Cost to provide advanced CLABSI education, thereby decreasing incidence of CLABSI outweighs cost of treatment of CLABSI. ICU staff. Increased knowledge and skill to prevent CLABSI. Patient. Decrease rates of CLABSI, improve patient care and outcomes, improve patient satisfaction by decreasing unnecessary length of stay. Overall decrease in CLABSI-related deaths benefit all parties.
The implementation for advanced education regarding central lines for ICU staff is highly feasible. Most hospitals already have continuing education, a nurse educator, infection control teams, and many of the resources required for this experiment. Some benefits which have already been discussed include reduced CLABSI rates, reduced length of stay for patients, reduced costs to the hospital related to CLABSI, which are generally, again, not compensated by insurance, increased staff knowledge and compliance of procedures, and improved patient outcomes. A risk that might occur during this experiment includes confusion by staff while implementing new protocols. Evaluation of the training will be monitored by nurse managers